This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, I'm Derek Stitt, and welcome to the Neurology podcast. In this episode, I'm grateful to be joined by Clemens Warnke, neurointensivist and neuroimmunologist at the University of Cologne, and one of the authors of an excellent review article in the Green Journal published in July entitled Progressive Multifocal Leukoencephalopathy, Pathogenesis, Diagnostic Tools, and Potential Biomarkers of Response to Therapy. This article is a great one-stop shop for neurologists for the need-to-know information regarding PML, as well as a glimpse into a hopeful future for this tough-to-treat condition. Clemens, thanks so much for joining the podcast today.
Thanks very much for having me on.
Clemens, your excellent review starts with a great background on JC virus infection and its risk factors. I was hoping you could start by reviewing which patient populations are highest risks for developing PML. And if we see this rare case of quote-unquote immunocompetent individuals who have confirmed PML, can that really even occur in the literal sense, or should we question that?
My first message to younger neurologists, hematologists, and those that frequently look at imaging of the brain, think of PML. If there's a patient with a defect in T-cell immunity, for example, PML needs to be considered. Why is this important? Because early recognition of PML is key for prognosis. The typical risk groups that you were asking are AIDS patients, individuals with hematological malignancies, post-transplant patients, those with rare genetic immune deficiency syndromes, and patients treated with some of the modern biologicals. In a historic perspective, the first two cases of PML published in 1958 had hematological malignancies, and later, with the AIDS pandemic in the early 1980s, PML was listed among the AIDS-defining conditions. Then from 2005 on, cases of PML in people with MS treated with the monoclonal antibody natalizumab were reported. And the other thing you were asking, confirmed PML should really lead to a screen aiming at detecting an underlying condition. Cases of PML in so-called immunocompetent individuals remain the very, very rare exception.
And as a quick follow-up to that, you mentioned patients treated with the newer biologics, and you mentioned natalizumab. Can you tell us a few other of some of the modern biological agents, the monoclonal antibodies, which have been associated with risk for PML?
Yeah, there's a long list, but often it's not in monotherapy. But in particular, in the MS field, you would see PML also rarely in patients treated with fumarates, for example, or S1P modulators or B-cell depleting therapies, but at much lower risk. So the main issue really was with the integrin blocking agents.
On the flip side of that, even for those who are profoundly immunosuppressed and have the classic risk factors for PML, most of them never go on to develop it, despite a lot of them inevitably being seropositive. Is there a hypothesis for why that is?
You know, you already made the point. JC is excreted in urine in a proportion of healthy individuals even. So I, for example, do live and work in a highly populated area in Germany, in Cologne. And here JC virus can be isolated from the river Rhine that crosses Cologne. So I think it's reasonable to assume that we all are exposed to the virus. So why do we not all develop PML? So viral genetic sequencing studies have helped us to understand this. Rearrangements in the JC genome are necessary for establishing symptomatic disease. So profound immunosuppression increases viral turnover and the development of viral gene variants in the infected host during the persistent infection. And then also our genes come in. In a study we, for example, conducted during my postdoctoral fellowship at the Karolinska Institute in Stockholm, we saw that antibody responses to JC virus are strongly controlled by our HLA genes. So to summarize, we are all exposed to the causative JC virus, but during severe immunosuppression, bad luck in a way, and our genes determine if PML-type viral variants will develop and finally cause PML.
That's a fascinating observation. Let's shift to clinical presentation. Can you tell us about the spectrum of the presentation that neurologists should know? Can you give us some heralding syndromes to look out for? And are there exceptions to the presentation where symptomatic JC virus infection needs to be considered? Because as your article so nicely teaches us, not all symptomatic presentation of JC virus in the CNS is PML.
Here, I would like to cite a paragraph from a case report. And this starts like you will hear now. JC was a 30-year-old man who had Hodgkin's disease for 8 years, developed a progressive left central facial palsy, left hypoglossal palsy, and palsy of the left upper extremity commencing in April 1970s. Derek, do you have a good guess where I took this from?
Would this be one of the first Sentinel reports, given that it's from the 70s?
Yes, right. Indeed, it's the description of the first PML patient of whom the causative JC virus could be isolated. So JC did not survive PML and the virus was found in his brain. So I think it's one of the typical descriptions, the subacute development of focal signs that can involve motor, but also sensory functions, coordination, and gait. All this is seen in PML. And also epilepsy occurs, and subacute cognitive and neuropsychiatric alterations are very common. While hemanopsia is frequently noted, indeed, unlike in MS, the optic nerve and the spinal cord are typically not involved. And regarding symptomatic JC infection other than PML, I think it's good to know granule cell neuronopathy. Here, the virus infects the granule cells of the cerebellum, and these are small neurons, not oligodendrocytes and astrocytes like in PML, and the patients develop progressive cerebellar signs. So other variants listed in literature, including encephalopathy, meningitis, or nephropathy, are very, very rare. And I would say their clinical relevance is marginal.
Great. Let's discuss imaging. I think those with even cursory knowledge of neurology vernacular can glean from the name alone that PML probably causes focal or multifocal white matter lesions on MRI. But please help us go further into the specifics of the lesion characteristics on MRI that are most suggestive of PML, especially compared to other mimics, with the obvious reminder that you always need to put these findings into clinical context and MRI alone is not diagnostic.
Here I repeat my first message. Think of PML, in particular when you look at MRIs of patients at risk. Many cases are missed in the beginning because PML is not considered when MRIs are reviewed. And it can be tricky. PML can start with small focal lesions that later expand. The typical multifocal appearance is a later disease stage with worse prognosis. So typical PML lesions are hyperintense on T2 flare and located close to the cortex and in the deep white matter. Also infratentorial involvement is frequent. So the lesions close to the cortex do not respect the border between the white and the cortical gray matter. You can call them leukocortical lesions, therefore. And in progressed disease, the lesions appear hyperintense on T1. This reflects the non-reversible demyelination. And PML with active viral replication show a hyperintense signal on diffusion-weighted imaging at the border of the PML lesions. And nearby larger lesions, multiple small T2 hyperintense lesions with or without contrast enhancement can frequently be seen. This is named punctate pattern or Milky Way appearance. And there's one other, I think, important point. PML in individuals with very bad immune competence, for example, untreated AIDS patients, typically show minimal to no contrast enhancement at first presentation. And this is termed classical PML in literature. Whereas in, for example, the natalizumab-associated PML, the immune system remains partially functional. Even the earliest MRI in these patients may show evidence of gadolinium enhancement and perilesional edema. So there's a difference also with regard to the risk groups, how patients can present on MRI.
That was an excellent summary. Thanks so much. So moving on to JC virus detection in the CSF. So if a patient has negative JC virus PCR in the CSF, how confidently can we exclude PML as a diagnosis? I mean, are there pitfalls with that test, if any? And how helpful are the standard CSF parameters with PML, like total nucleated cell count, protein, oligoclonal bands, et cetera?
I would like to put my second key message. Undetected JC DNA in CSF does not preclude the diagnosis of PML. So if you think this is PML because there's a risk situation and there are MRI findings that suggest PML, repeat CSF testing, send to reference laboratories for JC DNA testing, do biopsy if you still believe this is PML. For German natalizumab PML cases, we saw that more than 20% of individuals had a false negative PCR at time of first testing. And the reason is the CSF JC DNA load is often low, in particular with these drug-associated cases of PML. And commercially available PCR tests can miss these low copy numbers. You were asking about standard clinical CSF parameters as well. So these are often within the normal range in PML and do not really help when PML is suspected. And if you find abnormalities, they more relate to the underlying condition predisposing to PML. So slightly elevated leukocyte cell counts and protein levels are seen in AIDS, oligoclonal bands in MS, irrespective of PML.
Let me ask a little follow-up question to that and maybe give you a hypothetical scenario where you have a patient where you have high clinical suspicion for PML based on imaging and risk factors and presentation, and your initial CSF PCR returns negative. It was sent to a reference laboratory. In your clinical practice, are you more inclined to repeat CSF or go directly to biopsy at that point?
I think considering that in a way also in PML, I consider time is brain. So you want to be quick. If I had done this in my laboratory and send it quickly to a good laboratory and it turns back negative, I think the next step would maybe to repeat it once, but then also prepare for biopsy because you want to make the diagnosis. And if you are convinced this must be PML, looking at the imaging, looking at the clinics and the risk aspects, I think this is reasonable not to delay the diagnosis.
So for those cases that do move on to brain biopsy, when clinical and radiographical data are suspicious for PML, but the CSF is non-diagnostic, just like we said in that last scenario, remind us what are the pathological hallmarks on histology?
First of all, brain biopsy is still the gold standard of diagnosing PML. And what you see here for definite diagnosis of PML is demyelination, bizarre astrocytes, enlarged oligodendrocyte nuclei. And you need the tissue detection of JC virus. And this can be done by various different techniques. This can be done by immunohistochemistry or, for example, by tissue PCR. And what you also see in classical PML, that you have only a few lymphoid cells and many virally infected cells, whereas, for example, in the drug-associated cases or also in the AIDS patients that are already treated with antiretroviral treatment, a more pronounced inflammation is possible and often only a few virally infected cells are present.
I also wanted to highlight a nice section in your paper on what makes diagnosing PML such a challenge, where you mention how it can be tough for non-specialists who may have less awareness, especially because there really are no PML-specific symptoms. So you have to be thinking about it to find it, as you've emphasized multiple times already. However, for those patients who have been identified to be more at risk, you also discuss some methods to enhance awareness, prevention, and surveillance. And I was hoping you could tell us about those.
If you know that someone has HIV or is treated with natalizumab, has high antibody titers, new onset, for example, of hemianopsia must lead to appropriate diagnostic workup aiming to confirm or exclude PML. And with regard to prevention and surveillance, a systematic strategy is only in place for MS patients treated with natalizumab. Here we know that the risk is much higher when the antibody test, so the Stratify JC test, comes back positive and is even higher when the titers are high. So, and this has several implications. JC negative persons should be checked for seroconversion every 6 months. And the best way, in my opinion, to avoid PML in MS is to offer alternative therapy other than natalizumab to those that are or that become JC seropositive. Other options, such as extended interval dosing that may reduce the risk by reducing the exposure per treatment period, should only be offered if the patient rejects really to switch. And for these patients, PML MRI screening every 6 months or even more frequently is recommended. And here you can use a very short MRI protocol without gadolinium. And PML screening was implemented because PML typical lesions can sometimes be detected before developing clinical symptoms. And then this is what we call asymptomatic or pre-symptomatic PML, which has overall a better outcome. And that's kind of the reason for PML MRI screening in high-risk individuals.
Let's switch to a complication seen in patients with PML, and that's PML iris, or immune reconstitution inflammatory syndrome. I was hoping you could tell us the clinical scenarios where iris tends to occur, what it looks like on imaging and pathology, and what are the ways it can be managed depending upon the clinical scenario in which it occurs.
In a way, I think you can say that PML iris is a clinically relevant extreme of inflammation in PML. So the immune system comes back, attacks brain cells that are infected with JC virus and causes structural damage. In AIDS patients, it was first described as the unmasking of PML with new onset neurological symptoms following the start of antiretroviral therapy. And it was also used for clinical worsening following the start of antiretroviral therapy in those that were already diagnosed with PML. And a later PML iris was also reported in natalizumab-associated PML, when the T cells that are hindered to enter the CNS by this integrin blocking therapy come back after treatment stop. So it's rather obvious what you expect on imaging and in tissue. You see profound signs of inflammation, including contrast enhancement, swelling, lymphocyte influx. But what I want to stress here is to recover from PML, the virus-infected brain cells need to be cleared from the virus. So inflammation per se is not bad. You need it only if clinical symptoms worsen dramatically in this phase of the disease. There are reasons to intervene. Only then I suggest to call it PML iris. And in this situation, the standard of care is the cautious use of corticosteroids, because prolonged doses might interfere with effective viral clearance and could have negative effects.
Now that we've solidified our understanding of the diagnostic aspects of JC virus in the CNS, let's steer the conversation towards treatment of PML. So once we have the diagnosis, what are the core points of management or the standards of care, if you will?
At the core of treatment is to help the immune system to fight back and clear the brain from the infected cells, or the virus from the infected cells. Now, the earlier, the better. So think of PML, try to quickly confirm the diagnosis and then help the immune system to recover. The approach depends on the underlying condition. So treatment-naive HIV-infected persons shall start effective antiretroviral therapy. Treated AIDS patients shall be checked for options to optimize the antiretroviral treatment protocol and for compliance, of course. And individuals with drug-associated PML shall stop the therapy as soon as PML is suspected. Added value of the use of plasma exchange or immune adsorption for enhanced drug clearance in natalizumab-associated PML is not confirmed. And this needs to be weighed with the potential risk of triggering PML iris and also immunoglobulin depletion on a case-by-case basis. And in patients with primary immunodeficiencies or elderly persons where you rarely observe PML without finding really another underlying condition, Total IgG levels are often found low, and I would suggest to substitute with intravenous immunoglobulins within the label of the IVIG products available.
Now that we've talked about the bread and butter of management, give us the landscape of emerging therapies for PML. What treatments may be on the horizon, and has anything shown promise, or are there treatments that we have talked about or have been discussed previously that might be debunked nowadays?
Most promising are interventions, I think, that could enhance the JC-directed immune response of the host. So, for example, there's a prospective pilot study underway with long-acting recombinant IL-7 to enhance T-cell function. And other treatments that are tested and are used off-labelly are PD-1 blocking checkpoint inhibitors, such as pembrolizumab. And my personal impression is that a proportion of PML patients indeed benefit. Probably most advanced in the in the clinical development is the application of polyomavirus-specific T cells. So smaller clinical studies and case series supported at least safety and feasibility. The definite demonstration of efficacy remains to be investigated. My personal view, so weighing the currently available possible options, we do ask insurance companies in Germany to cover the costs for off-label use of checkpoint inhibitors, and on a case-by-case basis also for virus-specific T-cell treatments.
As a follow-up to that, in your own practice, is there one of those treatments that you tend to use more than the others for PML patients recently that you've seen?
Yeah, what we started to do is we have a collaboration with Hanover Medical School, and there they have in the transplant section the option to provide BKV, so a very closely related polyomavirus, BKV-specific T cells to PML patients. And what we do is we start with what we called the standard of care. But if we think this is not enough because we don't have really a situation where we can reverse the immune deficiency, then we start off with using PD-1 blocker, and then we ask the insurance companies to cover the costs. But then we test whether or not we find JC virus-specific T cells in blood. And if we do not find them, it's less likely that the PD-1 blocking treatment will work. And then we move on in single cases for this BKV-specific treatment. And this is how we go. But there's often some delay because you need to ask for cost coverage, and this can be critical.
Sounds like a lot of moving parts, and I'm sure practitioners here in the United States would have similar uphill battles with regard to cost coverage. Just so that I confirm that I understand correctly, those more emerging treatments like the directed T cells, PD-1 inhibitors, would be more typically used in patients where you can't, for example, induce an immune response by initiating antiretroviral therapy, or can't remove the offending agent like a biologic, correct?
Yes, there are several different opinions on that, but my personal view is if you detect early, for example, PML in natalizumab patients, and the last treatment episode is a few weeks ago, you might hope that the immune system comes back after treatment stop and you don't need to push the immune system more. But just recently, I had a patient with a history of severe immune deficiency, just a genetic syndrome, and there you cannot expect the immune system coming back by itself. As you said, in AIDS patients, you start antiretroviral therapy. You can hope that this works quickly enough. But I think we need the clinical studies here to show what patient group would still benefit from additional treatments. And overall, this is all experimental, what I told you here. And we need the clinical studies. And that's why we kind of do our research in this field to move this forward, because I'm optimistic that we could find also a virus targeting therapy in the nearer future.
For sure, that's for certain. In this manuscript, you talk about how finding better biomarkers to act as more reliable surrogates for treatment response is key for developing better therapies. Can you tell us why those biomarkers are needed and how you and your team at the German National Reference Center for Papilloma and Polyomavirus are working to address some of these challenges.
Yeah, you remember my second key message from the beginning. Undetected JC DNA in CSF does not preclude the diagnosis of PML. And the first goal of our own work is to work on changing this, at least for our laboratory. And we work on more sensitive tools for JC detection from CSF to avoid delay in PML diagnosis and also to avoid biopsies. And for example, we work on pre-analytic steps. We use different PCR protocols, modern droplet digital PCRs, and we enrich, for example, extracellular vesicles to concentrate the virus in the fluids. But the other aspect indeed is to work on surrogate markers that could be used in clinical trials to assess response to therapy. And I think a study in PML can only be successful if you have a very good study endpoint, because the disease is rare. It occurs in heterogeneous risk groups with variable prognosis. So to reach a strong clinical endpoint such as survival might prove challenging. And the other option is to look at markers of viral activity and response to the virus. So if we could convincingly show with an intervention that the viral load in body fluids rapidly decreases, or the virus-specific T-cell responses increase, or neutralizing capacity of antibody responses to PML viral variants increase, then I think we are more likely to be successful in these phase 2 treatment studies. So that's why we work on these biomarkers.
Thanks so much for reviewing those. Those are some very exciting aims. I just want to thank you for joining us today. I think you provided a lot of excellent pearls. I can't summarize them all, but your championing of awareness for PML, as it is a too often overlooked diagnosis. Also emphasizing that a negative PCR does not rule out the diagnosis, and not being afraid to go for biopsy if the clinical suspicion is high and it's reasonably safe. I think I also liked your emphasis on not being too aggressive with immunosuppression and iris. And I really like you explaining what's on the horizon with regard to research and biomarkers and emerging therapies. I just wanted to give you the floor to mention anything else that you'd like that we didn't cover regarding your article or this topic overall.
I think you really asked the right questions. There's not much I can add, but also with regards to perspective and the future, looking at the recent advances in, for example, gene therapy and how fast COVID-19 vaccines and treatments were developed, I think we can be positive also for JC virus and PML. We know the target and we have the techniques, and any company designing novel immune interventions should be interested and invest in the PML field to avoid a devastating possible complication. And I think we are here to collaborate.
Certainly. And I think there's lots of reasons to be hopeful. So with that, thanks again, Clemens, for joining us. I'll encourage everyone to go check out your article in the Green Journal. And I want to thank everyone for listening. That's all for today's Neurology podcast.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.